All right, and in this audio lecture, we're going to be talking about sodium and sodium disorders, right? So specifically, this lecture is going to be coupled with hypernatremia, which is elevations in blood sodium. But before we get into the description of the events that happen when you get elevations of blood sodium, we need to talk about the roles of sodium in the body. So unlike potassium, the roles of sodium are going to be less involved in membrane potential and more involved with osmolarity and water-based balance. And also, they will contribute towards acid-base balance as well. Sodium is the most abundant extracellular cation at 145 milliequivalents per liter. Okay. It does contribute to membrane potential, but not as substantially as potassium goes. So potassium really contributes towards resting membrane potential because the cell is more permeable to potassium compared to sodium. So changes in sodium really disrupt membrane potential, less so than we see with potassium. So we see the concentrations of sodium can vary with renal function. So increased glomerular filtration rate leads to increased sodium losses in the kidneys, and then reduced reductions in glomerular filtration rate result in reductions in sodium excretion. So we see that the system is regulated, really sodium concentrations are regulated by this renin-angiotensin-aldosterone system. So this system is primarily going to, angiotensin 2 primarily regulates blood pressure and then vasoactive properties, but it does affect renal flow, and so it's going to reduce renal flow while also stimulating aldosterone release, which aldosterone is incredibly important in sodium regulation, and it's going to be the salt-saving hormone in that it acts on the kidney to increase the sodium reabsorption. Okay. Now we need to talk about sodium sources versus sodium losses. And so we see that sodium enters the body through multiple mechanisms. Most of the time it's entering through food. Okay. These are going to be through processed foods, and then excretion occurs through the kidneys, right? So first of all, we have the source being dietary, and then the loss being through renal activity. But we could also see losses be from vomiting or other gastrointestinal disorders like diarrhea. Another source of loss is going to be nasogastric suctioning or even burns. So these burns can act as a reservoir for this sodium loss. Sodium also, on the last slide I said it doesn't really contribute much towards membrane potential, but is involved in action potentials, right? So membrane depolarizations. So when we have those neurons, and then they receive a local potential that is strong enough to reach threshold, now an action potential is generated, opening up voltage-gated sodium channels. Now sodium enters the cell, and that is responsible for the membrane depolarization. So now the membrane is becoming less negative, and then eventually these voltage-gated channels close, and then potassium starts to leave the cell, resulting in repolarization. So the first disorder that we're going to talk about is hypernatremia. Hypernatremia is going to be concentrations of sodium above 145 milliequivalents per liter. A milliequivalent is the same thing as essentially a millimole. It's just another unit that is accounting for charge rather than this concentration measurement that's presented right here. So when we see increases in sodium, we're going to expect the serum. This would be the plasma portion of the blood. So the watery portion of the blood, the osmolarity increase, because now we're increasing the number of solutes in there. And so by creating a hypernatremic solution, we're essentially creating a hypertonic extracellular fluid. And anytime we have a hypertonic solution, now we are going to be stealing water from our cell. So this is responsible for actually generating the thirst sensation. So what we have here is this is hypernatremia over here, and we have gain of water or a loss of water as the cause, and now that leads to an increase in sodium concentration. Now, osmosis works by moving water into and out of a compartment, and this compartment in this case is going to be the intracellular compartment that normally we sit in between 280 and 290 milliosmoles. When the concentration of the serum or the plasma increases to an extent, what's happening is the solutes are increasing. This is the extracellular fluid here. So in the extracellular fluid, the solutes are concentrating, and now it's going to be drawing water out of the cell, and so the cell's volume actually is reduced in the process. Okay, this is how the osmoreceptors in the hypothalamus work. So the hypothalamus is where the osmoreceptors, so the receptors that measure the osmolarity of our body fluids, and they respond by increasing and decreasing in fluid volume, and then that stretches the cells, and then we get hormone secretion, specifically antidiuretic hormone. So hypernatremia can be caused from excessive sodium. So this could be excessive sodium intake. Either maybe you like chips too much, or you like fast food too much, or you just like processed foods too much. Okay, those all have high sodium content. You could also be admitted to a hospital and receive a hypertonic saline solution. And so your textbook says 3% saline. Well, anything really above 0.9% saline, which is normal saline, is going to be considered hypertonic. Okay, so you would deliver hypertonic saline in the case that maybe you're suffering from water intoxication, right? So that fluid excess due to the hypotonic environment that is created, like from excessive water ingestion without solutes. We could have Cushing syndrome, and so Cushing syndrome leads to increased intestinal absorption of sodium. So Cushing syndrome is going to be excessive cortisol secretion, and so this cortisol elevates blood volume by increasing sodium absorption in the gastrointestinal tract. Okay, so this is in an attempt to increase the blood pressure to make sure we are maintaining the driving force. Okay. Another way we could have this is we're getting corticosteroids. So prolonged corticosteroid use can result in this excessive sodium. So remember that water oftentimes follows salts, so always follows salts. Anytime that we ingest more salts, now we're going to be retaining more water in that process to balance out the osmolarity. The second example here is water loss. So water loss without solutes results in dehydration. So now we are actually concentrating the extracellular fluid. We're not adding additional sodium to it, but we are concentrating the sodium ions in the extracellular fluid by decreasing the water volume. So one way to have this happen is a reduction in water intake. So if you go a day without drinking water, you're likely going to be dehydrated and you're not going to be feeling too well, right? So this could be due to decreased thirst or really decreased desire to thirst. And one setting this can happen in is in the hospital, right? Or when somebody is in an unconscious state, maybe, and their food has a lot of salt in it, now they have this inability to trigger the thirst reflex. Okay, so we can see sedation work there. Third spacing. Third compartment spacing is talking about the movement of fluid from the interstitial fluid into the serous cavities, right? So like synovial membranes, pleural cavity, the pericardial sac. Now that water, once it gets in there, really has a difficult time getting back out, and it can't really be involved in exchanging anymore. So pleural effusion or pericardial effusion can result in this hypernatremia, because in that is taking mainly water. Vomiting and diarrhea, like we've already covered with those gastrointestinal disorders. Excessive sweating. So sweat, like we talked about in cystic fibrosis, we actually reabsorb a lot of those ions that are lost in the sweat. Now, we do lose some, but we don't lose them at the same ratio that we lose the water. Okay. Hyperventilation. So if you're breathing too much, remember that our breath has water vapor in it, and so if you have chronic hyperventilation, such is the case During respiratory disorders, maybe you are suffering from respiratory acidosis and you have this chronic hyperventilation, and in an attempt to correct it, even though that wouldn't be effective after 24 hours, it could result in this hypernatremia, right, and dehydration as a result. Diuretic use, so caffeines, Lasix, any kind of loop inhibitors that are going to reduce water in circulation. And then really the diuretic use doesn't have too much an effect on sodium, but it is removing water from the system, and it concentrates the sodium in the process. All right, so we could have diabetes insipidus. Diabetes insipidus is the malfunction, so this disruption in antidiuretic hormone secretion. Right? And so if we have this reduction in antidiuretic hormone secretion, remember that antidiuretic hormone is secreted during times of increased osmolarity and to increase absorption of water in the collecting duct and the distal convoluted tubule. And so if we don't have that antidiuretic hormone, we are losing more water, and then that is concentrating the sodium in circulation. Okay. So we have a number of manifestations. Hyperthermia. Okay. So in addition to that, hyperthermia can result in warm and flushed skin, okay, dry mucous membranes, and this is going to follow the dehydration aspect. Dysphagia, which is difficulty swallowing. So if you have a reduction in saliva, then swallowing becomes difficult. We could have an increased thirst, and that's a dipsogenic response. The irritability and agitation is due to nervous dysfunction at this point, because now we are stealing water from our cells. Okay. As a result, we could generate weakness, have headaches and seizures, which are all going to be neural in origin. Lethargy and coma, which coma is really an extensive neural dysfunction. Now we could have hypotension due to the dehydration, okay. Tachycardia as a result of the low blood pressure and the reduced cardiac output due to the decreased blood volume. So the tachycardia is really a compensatory mechanism. With the hypotension, we see that a weak pulse could also follow it, and that kind of makes sense. These two really oftentimes go together. We could get edema, right? So the edema could be the result of fluid accumulation inside of the interstitial space. Okay. And last but not least, we could suffer from reduction in urine output. Now, you'll notice that a lot of these are due to water volume, but things like decreased urine output could be due to really this increase in sodium concentration or this decrease in water concentration. So, diagnosing this disorder, we're going to use a history and physical examination, okay? And we're going to be looking for any number of the previous manifestations. We're going to be running blood chemistry, looking for changes in blood sodium, and so we would be looking for a value above 145 milliequivalents, and then a urinalysis. So the urinalysis is going to tell us about the concentration of the urine, so we might measure the specific gravity. We might measure the volume produced, or we could just measure the sodium content to look at the glomerular filtration. All right, so to treat hypernatremia, first and foremost, we're going to try to replace any fluids. Now, this could be due to just normal drinking, or it could be due to, or we might try to deliver it through intravenously. And so oftentimes we're gonna have to be very careful about really replacing this too much, because if we replace the fluids too quickly, then these cells can actually swell. So we are creating a hypotonic solution if we infuse water, or even a too low of concentration of that water. And so oftentimes we buffer it with sugars, either glucose or dextrose, to try to buffer this. And so gradually reduce the difference between the osmolarity of the intracellular fluid and the extracellular fluid, because we could cause really central nervous system damage. Now, if the hypernatremia is associated with hypervolemia, so hypervolemia is a fluid excess, right? We want to really administer the loop diuretics to increase urine production and urine output. So by increasing urine output, we're going to be increasing sodium excretion, and so that might be another technique. Finally, we need to make sure we are taking care of seizures and neurological defects, and we're adding those to the patient care as well. That is the end of the hypernatremia audio lecture and the sodium introduction.